So some of the slides are the same, just introduction to pharmacogenomics here. So when we give a drug to a patient, even after we do the targeted therapy, many factors determine the efficacy of drug. So, height, body weight, sex, age, disease, all of these are contributing factors that how the patient will respond to a drug. Okay, organ function, physiology, environmental factors, all of them feed in. You give chemotherapy to a young person versus an old person, a healthy person versus a non-healthy person, regardless of age. They, they all are going to react differently based on that. And so drug could be toxic or beneficial. I have not taken too many prescription drugs, but I have reacted very strongly to a few drugs, even I have, and I could not figure out why I have such strong reaction. So up until recently I did not know, and now I know that there is something different about, my metabolism. So, but pharmacogenomics is this part only. So this is one part we are considering out of so many different things here. Okay, so this you already know. So this is just showing you the advent of pharmacogenomics. It's a relatively new thing. So this thing, FDA approved pharmacogenomics biomarkers like the one I showed you in that table just in 2014. So it's a very recent thing. People did not even understand this thing. Okay. So this is just to show you that some people really respond well to a drug, same disease, same intensity, everything. Other people have no effect, some people have side effect, other people are hospitalized because of that, and there's all this thing, and you have to give a huge variation in dosage. Okay, so one size does not fit all. Okay, there is a variability in response, severe toxicity, therapeutic failure, and many times people are hospitalized with serious thing. Okay, so the key determinants in pharmacogenomics are pharmacokinetics and pharmacodynamics. Okay, so pharmacokinetics is the one which I just told you, right? Can you remind me what is pharmacokinetics? ADME, very good, ADME, right? What the body is doing to the drug, exactly. So that will determine drug's level, right? Body gets rid of it quickly, it's not there. Body is letting it metabolize slowly, it is going to be there. And pharmacodynamics, what the drug is doing to our body, very good. Okay, and these two things are the main determinants for pharmacogenomics here. So pharmacokinetics is what the body does to the drug, which is ADME. ADME, if you don't know, it is ADME, right? So many of you will make small molecule inhibitors for something, for some disease, right? So once you do it in cell line and test it, and you're testing in animal model, right, then you have to do ADME, right? Then pharmacodynamics, what the drug is doing to our body. We saw many examples yesterday also. Germline and somatic mutations, germline are inherited from patients. PGX deals with germline mutations. Somatic with respect to cancer is mainly about the tumor, right? If the tumor, what exactly is wrong with the tumor? This is a very famous mutation. Now I'm going to give you some examples. So suppose there are 4 scenarios, right? So this kind of tumor is overexpressing the receptor. This has fewer receptor, this has no receptor, it has different kind of receptor. Okay, and let's say it is HER2 receptor. So if you give Herceptin, it is going to be very effective here because it has too many receptors. This will probably also respond. This is not going to respond because there is no HER2 there. And then this is going to respond or not? The last one? No, because it is not meant for this receptor, right? So this will have no response. So does this come under PGX umbrella? Raise your hand if you think it is yes. Thoda sa upar so that I can see it. Okay. And raise your hand if you think it is not under PGX umbrella. If your answer is no, raise your hand. You are the only one who is right here. Provided we feel like we have achieved such a big thing, right? We all do. I also feel the same way every single time. Okay. Okay, to make all of you who raised your hand right, what would you like to see here to make it come under PGX umbrella?
Because the receptors, like the formation of receptors is encoded in genes. So that's why I'm relating it to the germ.
Germline. So what is the difference between germline and somatic mutation?
Somatic cells are like every cell of our body. Germ cells are the...
it is the other way around. Yeah, it is the... I was going pretty quickly because I was thinking you guys got it, but I'm very glad you got confused because I'm sure somebody else is also confused about that. So what happens is that germline means egg and sperm, right? So when the zygote is formed and when it divides, basically every cell of that particular progeny will have that mutation. So it is a germline mutation. In cancer, when we say somatic, we are basically talking about the tumor itself, right? So that is somatic. So that tumor, whatever mutations have been acquired there, that may not be germline thing. So like we were born healthy, we remained healthy until 70, 80, whatever age, and then somebody develops a tumor. So it's obviously not germline thing, right? There was some environmental change or whatever it was. Something external went wrong to give rise to that tumor, right? So that's not germline, that is somatic.
And also, somatic will have this 23 pairs of chromosomes. Germ will have only 23 chromosomes. Is it?
No, so once the zygote is formed, your pairing is all done. So it depends on the parents. So for example, cystic fibrosis, right? So the father is the carrier, mother is the carrier. So one defective gene in each of them. So, and cystic fibrosis is very uncommon in India, okay? Very, very uncommon in India. It is very common in people from the Western world. But my friend, she was a carrier of cystic fibrosis. Obviously, she had no idea. And her husband also turned out to be a carrier of cystic fibrosis. And when they had a son, he has cystic fibrosis. And cystic fibrosis, you know her, I'll tell you later. So when cystic fibrosis, some time ago, the average age was 12 years. Then 16 years. When my friend's son was born, it was 20 years. And the good news is there now it is better. So she was very worried, and I don't know, I was putting together this presentation, and cystic fibrosis is one of them. So I checked her son today online to make sure he's all right. He's the president of a very big financial company, and I'm sure he's in his 30s or late 30s or something like that. I didn't calculate, he's 1995 born, so 30 years old. So he's all right. He's doing very well, so that's the good news. But when he was born, the average age was 20 years. So my friend was hoping by the time he grows up, some therapy comes, and now there are many therapies. So the point here is that some disease will show if you have only one allele, but other diseases will manifest. And they're both from Kashmir, so they are Indians. But, and it is extremely rare to have that mutation in Indians. But it happened just that the two carriers got married and the child has it. And the child has 1/4 chance of getting it, you know, the Darwinian rules. But go ahead.
But for cystic fibrosis, it is like there is high chance of possible for somatic mutation because cystic fibrosis occurs because of 508F mutation.
There are more than one mutation and there are more than one ways of having cystic fibrosis. In some cases the channel is defective, in some cases the channel is not made. So there are many variations of cystic fibrosis also. And if it is somatic, your child cannot get it. Your child will not get it if it is somatic. Because it has to come to the egg and the sperm before it is transmitted to the progeny, right? So those of you who raised your hand, right, justify this why it is a PGX. You can justify it. Sometimes when we make a mistake, we justify it, especially as children, we always try to justify it, right? So you can actually justify it scientifically. Can you justify it?
If the issue is inherited from the parent.
Exactly, then it could be PGX, right? So if we inherited this from our parents, that we have too many receptors, that's a different thing. Then the person will get this tumor as a child, right? Because it is an inherited thing. If it was inherited, then it could be a PGX. That most of the time, this kind of thing is not inherited. This is a tumor-specific thing. In that case, you guys are correct. Okay. So when receptor differences are PGX, if the difference in receptor type, structure, expression is caused by germline genetic variation, then it is PGX. But if it is in the tumor, somatic, it is not PGX. Okay, germline, yes. Epigenetic disease, drug exposure caused it. No, it is not PGX. Okay, tumor mutation, not PGX. Okay. So receptor differences are PGX only when they are caused by inherited genetic variants. Okay, same thing about this thing. So this cell has a lot of receptors to take this drug. So drug gets in. This one has less receptors. So if your cells have decreased uptake of a drug, the drug can build up and cause problem. Is that PGX? Can you tell me that? It can be PGX if only the decreased uptake is caused by inherited genetic variation. It is as simple as that. Okay. So when decreased uptake can cause toxicity, if cells cannot take up a drug properly, drug remains in the blood or extracellular space, systemic concentration increases, that can be toxic. So there is a problem there. You take a drug and it is not taken up. So it is not going to be effective because it is not reaching its destination. Plus, because it is not taken up, the blood levels are going high and high. The drug, so it is causing toxicity. So both ways it is a lose-lose situation, right? Okay. Again, if the decreased uptake is PGX, if only it is due to the germline variants. Okay. When decreased uptake is not PGX, because it is due to drug-drug interaction, or there is organ damage, or there is inflammation, or hypoxia, or something else, then it is not PGX. Okay. Drug breakdown. So normally the drug is breakdown, so you give the normal dose of the drug. If it is fast breakdown, you have to give more drug. If there is less breakdown, you have to use less drug. Okay. So this is just telling you about targeted drug development. This is not necessarily pharmacogenomics unless the target in the cancer cell is an inherited gene. Okay. So now let's look at the case studies. Okay, and that will tell you the significance of pharmacogenomics. So statins, you know, these are given for high blood pressure, right? So there is many people. So for statins to work correctly, they may first be taken into the liver. Statins are transported into the liver by a protein made by this gene. So you may not know this thing. Many times genes have a different name than the protein. Many times the protein names and the gene names are same. Other times they are not the same. So remember that PGP1 I was saying, that is the gene name. Gene name was that ABC, all that big name, and the protein was, yeah. So this is the gene name, SCLO1B1 gene. Okay, so some people have a specific change in this gene which causes less of a statin, cause simvastatin to be taken in the liver. So when taken at high doses, this drug can build up in the bloodstream. So this can cause muscle problem, including weakness and pain. So simple blood pressure medication. So it is not going in the liver, so it's not going to help the person because the drug is not going to work, but it is building up also. Actually, that is not true, because the liver is not the one which is affecting a liver, is just metabolizing the drug. All the drugs are basically, most of the drugs are cleaned up by the liver, right? So if it builds up in the blood, it will be toxic to the patient. Okay, so if the doctor is prescribing this drug to you, then that doctor should test for this gene. So see, here it is not going in the liver. Okay, here it is going in the liver, here it is not going. So look at that, how much it is building up in the bloodstream. Okay, this is another case, depression and amitriptyline. So this is an antidepressant drug. Okay, so the breakdown of this antidepressant drug is influenced by two genes called CYP2D6 and CYP2C19. So if your healthcare provider prescribes amitriptyline, they might recommend genetic testing for these two genes to help decide what dose you should do. So what these proteins do, if you take amitriptyline, it demethylates to form nortriptyline. Okay, and this nortriptyline is then hydroxylated to these products. So either amitriptyline is directly hydroxylated or nortriptyline is hydroxylated. So if you break down amitriptyline too fast, you will need a higher dose for it, or you may need to use a different drug. If you do break down very slowly, you may have to take smaller dose there. Okay, have you guys heard of this drug, amitriptyline? You have. In what respect? In serotonin receptor. Some doctors also prescribe it for headache. It is not a headache medicine, but they do prescribe it for headache also. You know that?
Yes, ma'am.
Have
My family has been
prescribed for headache. And did it work for that person?
It did, but we were very hesitant because it is an antidepressant drug. So we did ask for another opinion, and they gave us something
I
else.
guess it is like serotonin reuptake inhibitor or something.
But it is an antidepressant drug.
This drug is also administered during traumas if somebody is having trauma. I have seen.
And did it help?
Yes, ma'am.
It helped.
Yes,
Okay.
ma'am.
Okay. Let's talk about it at lunchtime. Okay. Okay. Cystic fibrosis. Okay. So cystic fibrosis is caused by genetic changes in this gene called CFTR gene, which affects the CFTR protein. So what this does, this protein forms a chloride channel which acts as a passageway to move chloride across the cells in your body. So it looks like that. So cystic fibrosis patient, either they don't have this drug or they have a defective channel there. So what it happens is that chloride cannot go this, and water is also, I don't know, water can go, but these people, they develop mucus in their lungs and infection in their lungs, and basically it's very bad disease to have. So they have to do extensive exercise, they have to live in extremely clean environment, and possibly even isolated from the rest of the people, because they cannot be exposed to just everyday's, germs. Okay, so this is showing you when there is no cystic fibrosis, things can go in and out of the channel. Now, if you give this drug, ivacaftor, and this is a cystic fibrosis damaged this thing in a patient. So if you give this drug, it opens up the channel and things can go back and forth. So this is good. But there are also cystic fibrosis patients which do not even have this channel. So if you give this drug, it is not going to work because it can only open up the channel. If the channel is absent, the drug is not going to work. So basically, before you prescribe such drugs, you have to do genetic testing to see exactly what it is. Okay, then we come to Herceptin. So Herceptin, as you guys know, it treats HER2 positive breast cancer. It binds to HER2 receptors. and this is overexpressed due to specific gene profile in the tumor. Okay. Now 5-fluorouracil. So tell me this one. Is this a PGX umbrella?
No, because the overexpression is caused by the tumor.
It is not a PGX. I did not remove it because it was supposed to be a question thing for you guys. So this does not come in PGX umbrella, but again, if you go in literature, some people will put it in the PGX umbrella. It is not. Okay. Okay. This is another one. This is 5-fluorouracil and Xeloda. So 5-fluorouracil is a widely used chemotherapy agent, and this enzyme DPYD is responsible for the breakdown of more than 80% of the administered 5-fluorouracil in inactive metabolites. So when that is absent, 5-fluorouracil accumulates to toxic levels, leading to massive cellular destruction. So basically chemotherapy will kill the person, right? So before this drug is administered, one has to test for this enzyme whether it is functioning or not functioning. So standard dose more than 80% is inactivated, but when these variants are there, nothing gets inactivated, which causes lethal toxicity. Okay. So this is that drug. It is just showing you that it inhibits thymidylate synthase. Do you guys know which enzyme is thymidylate synthase? Have you ever heard of?
It is involved in folic acid synthesis.
Very good. It is involved in folic acid synthesis. But what is the role of thymidylate kinase itself?
Conversion of something, it is converting.
It forms thymine. The thymine thing is the CH3 group which is attached there. That is thymidylate synthase thing. It is involved in folate receptor pathway. You know why? Because that THF, tetrahydrofolate, is the methyl donor for thymidylate synthase. Okay.
So the antimetabolites which we give, they inhibits this drug like DHFRase and thymidylate synthase.
Say that part again.
The drug.
I am not going to answer till you use that. That's what we figured out yesterday. Yes, go ahead.
So those drugs we were like you said earlier, mercaptopurine, then 5-fluorouracil. These are antimetabolites which act as a pseudo like nitrogen basis. So they inhibits this DHFRase and this synthase enzyme.
So there are slightly different mechanisms. So when you have 6-mercaptopurine, it has nothing to do with thymidylate synthase or DHFR, because they get incorporated in DNA and RNA and they basically damage it because they are not the natural basis. So that is different. But when you are using 6-fluorouracil, right? So 6-fluorouracil is this compound here. Or you attach the sugar here, right? So this is 6-fluorouracil. And what is thymine? It is this thing here. So if you put the fluoro group here, it is mimicking thymine, right? So this can actually inhibit thymidylate synthase. So this is different from 6-mercaptopurine versus 6-AZA-T, because they are actually getting incorporated in DNA. Okay? So this is very toxic to the cells, but it has to be cleaned up. And if it is not cleaned up, it will kill the person just because of that. So you're giving a drug without testing and you're basically killing the person. Okay, because 80% is inactivated, right? Okay, now, so this is a real world case. This is actually a real case. He's the doctor here. So standard drug for this 6-fluorouracil prodrug, it is given as a prodrug which then becomes 6-fluorouracil. So this capecitabine is given. So within one cycle, this lady, she developed grade 4 mucositis, severe mouth ulcers, grade 3 diarrhea, and had foot syndrome. And genotyping revealed that she was heterozygous for this gene. So somebody was asking me, I think Venkatesh, you were asking me, that how do you know, or who was asking me, I'm sorry, somebody, one of you were asking me, how do you know which drug to, okay, yeah, you were asking me. Can you remind me your name again? Anshul. Anshul.
Anshul.
I heard Anshu, by the way, that time. Anshul, yes, Anshul was asking me. So, when this doctor gave the drug to her, obviously this was not known, but then at least he figured it out that this is the problem there. So now anyone who would give this prodrug, they should test for this before they give this therapy. Okay, so this is a consortium. So there are the guidelines for DPYD. If it is a poor metabolizer, that means it is not metabolized, don't give this drug. If it is an intermediate metabolizer, do 50% dose reduction. Only if it is a normal metabolizer you can give this drug, okay, at the recommended thing. The next one is UGT1A1 and irinotecan. So irinotecan is a product converted to SN38 active metabolite, which is 1,000 times more potent, okay. And this enzyme UGT1A1 conjugates SN38 for biliary excretion. So obviously if you have problem in this variant and if it is less active, reduced expression of this enzyme, they are at higher risk for severe diarrhea and low white blood cells. Okay, so genetic testing is required. Okay. So suppose you are reacting very strongly to some drug and people are normally taking that drug. So that is probably telling you that there is something genetic in our body that is not allowing that drug to be used.
This enzyme conjugates means it forms a covalent bond. No?
It forms a covalent bond and gets rid of it. I have not included the structure, but you know, I have seen this thing many times, and I was trying to recall SN38 because it has come across many studies, but I can't remember. So sometimes they attach a lipophilic something and get rid of it. So imagine that 80% is excreted. Yeah. So that is it has to be cleaned up pretty quickly because these are pretty toxic stuff. Tamoxifen is a drug for breast cancer, right? My friend, she had breast cancer long time ago, long time before I met her, and she was completely cured because of tamoxifen, like 100% cured.
You said yesterday on
No, this is yet another person. Yet another person. No, just tamoxifen completely cured her. And when she was in her 20s, and when I met her, she was in her 50s. So tamoxifen is used for breast cancer prevention. This is tamoxifen here. So this is metabolized to 4-hydroxytamoxifen, and this is also converted to this compound and this compound. So there are many enzymes involved in metabolism of tamoxifen. So tamoxifen is a prodrug with weak anti-estrogen activity. So what that means is that you all know that females, they have estrogen hormone and males have testosterone. We all know that, right? So many drugs, especially like breast cancer, there is a kind of breast cancer which feeds on estrogen. So more estrogen, more growth of this thing, right? So this is tamoxifen is anti-estrogen. The reason the spelling is weird here, okay, it's not weird here. Estrogen is written in two different spelling. Estrogen is ESTO, and some countries it is written as OESTRO. So you will see both the things depending on from where I took the figure. So tamoxifen mimics estrogen, but it is not estrogen. So it will bind to the same receptor, but it will inhibit the signaling pathway. Okay, so and then it requires bioactivation to endoxifen, right? So tamoxifen is given and then it is converted to this, and this is 100 times more potent than tamoxifen. So poor metabolizer will produce very little endoxifen, receiving a placebo effect. Do you guys know what is that? How many of you do not know what is a placebo effect? because it's a very fun thing. Oh, you don't know that, right? So whenever they do clinical trials, right? Whenever they do clinical trials, I have a slide for clinical trials also, which does not fit anywhere in any of the lectures. So I put at the very end of one of the lectures today just to tell you what exactly is going on in clinical trials and what is phase 1, phase 2, phase 3 clinical trials. But you know there are these clinical trials before the drug is approved. So in clinical trials, it is a necessity that suppose they take 100 patients. So they will tell these 100 patients that you are all receiving the drug for the same disease. Whatever these 100 patients have the same disease, right? So they say, oh, you are all, they do the consent that if something goes wrong, they are not responsible. So they take the drug, but they don't give the drug to everyone. A large portion of them will get sugar pills or some useless pills, right? But the person will think they are getting the medicine, right? And many times those people who are getting sugar pills, they get cured. The people who are getting medicine are not cured. And this is a very, very strong thing. So that is a placebo effect. You believe so strongly that you are getting such a wonderful medicine that you get well. That is called placebo effect. So when a drug works, they look at what percentage of people had placebo effect before they say the drug has worked. If a large people just got well because of the placebo, probably the drug wasn't working. Okay, that is placebo effect. So here it makes sense that if this enzyme is, either of these two enzymes are not going to work, this is not going to work. And if the cancer is disappearing, that is a placebo effect. It's not the real thing, right? That is why we always tell if somebody is suffering from a disease, right, you have to keep the moral up that you are going to get well, you are going to get well, you are going to get well, because that placebo effect can really do miracles. You cannot say a negative thing to a person with a serious disease. Okay? So, endoxifen is 100 times more potent than tamoxifen. Okay? So, poor metabolizers, if these enzymes are defective, endoxifen will not produce, and it is basically placebo effect. So studies have shown that patients with poor CYP2D6 metabolizer genotypes are more likely to experience breast cancer recurrence. It will come back with worse survival rate, which makes sense, right? And clinical applications, so pharmacogenomics testing can identify patients who may not benefit from tamoxifen and could be a candidate for alternate therapy. Okay, so this is very serious thing, pharmacogenomics. Okay, and now it is so this is estrogen receptor. So estrogen comes in, binds. This is a nuclear hormone receptor. So they go in and bind, and they turn on the signaling. Tamoxifen binds at the same place, but it does not turn on the signaling. So that is how it switches the signal off. Okay. All right, so precision medicine, we all know how important it is, but now you understand how PGX is equally important along with precision medicine. Okay, so somatic pharmacogenomics, I included this to give you an idea. So literature is filled of pharmacogenomics where they have included non-germline mutation, and they label it somatic pharmacogenomics. That means the tumor pharmacogenomics. This is not classical pharmacogenomics, but they still use this quite a bit. Okay, so if you are going there and calling it somatic pharmacogenomics, which is not the classical PGX, then obviously every mutation in the tumor will be counted under this umbrella. Okay, all right, but once again, let's stick to the fact it is gene-based, germline gene-based thing, okay? And these are the main things which are tested: drug metabolism, drug transport, drug response. These are the things which are included in this thing. This is genotyping, which is very, very easy, right? You can do targeted genotype, PCR or TACMan. Many of us do PCR all the time. It's so easy. Next generation sequencing, turnaround time. Treatment often cannot wait 2-3 weeks. Who takes 2-3 weeks for PCR, right? When COVID was happening, they took my mouth swab. I was feeling sick one day and I was thinking maybe I got COVID. I did not have COVID, but you know, at that time you felt slightly sick. You thought it was COVID. It was right of it. They took it, and 1 hour later, by the time I went home, they told me I didn't have it. So it doesn't take 2-3 weeks, but okay, structural pharmacogenomics and functional pharmacogenomics. It's not that important, but I will still tell you the significance of that. Structural pharmacogenomics means genetic variants due to the change in the structure of the protein that it is doing. It's like CYP2D6, right? So if this is not working, that means there is some mutation in the protein. That is structural genomics. But can you tell me some other way that there is no mutation in the protein, but it is still not working? Can you tell me any other way?
Enzyme inhibition by any other drug?
No, it is germline. So there is no drug involved at that stage. What could be in the germ line that without mutation something is ineffective? Suppose, let's say CYP, just make it simple. CYP is the one which is metabolizing a drug, right? And it is present in this level in normal cells, right? And it undergoes some mutation and it doesn't work in another individual, right? What else could go wrong with this thing when it doesn't work? Mutation is one thing. What else could go wrong? It can be degraded somehow, right? And that would make it wrong. Okay, what else? Germline is DNA expression. And how will you regulate expression? Hey, you guys were so good in that particular topic. So epigenetics can dictate whether the protein is made at the first place or it is not made at the first place, right? That is functional genomics. Okay. So structural is that the protein itself is changed, and functional is that gene expression, protein abundance, that is changed, and that is often due to epigenetics. Okay. All right. So now we know all these techniques. So this is PGX is part of the story, but we do identification of drug targets, we validate them, we identify disease associated pathways, okay? Validation, we do CRISPR, we do genomic guided drug development, personalized medicine, and pharmacogenomics is coming here. You have found the drug and everything, but you have to make sure that you do the testings. Okay, so the benefits are great. Before even you give the drug, you know whether it is going to be toxic or not toxic. You are going to know what dose you should administer, because here there is no room to do trial and error kind of thing, because these drugs are so bad to start with. You cannot afford to give the wrong dose to these patients. Okay, so it decreases overall risk for patients. It identifies genetic predispositions to side effects, tailored dose and drug selections for your genome there. Okay, so overview of current and future cancer therapy approaches. So chemotherapy is one fit all approach kind of thing. You just give, like I told you yesterday about that lady who went, she had HER2 positive cancer, they did not test it, they gave her chemotherapy, she died. Okay, so you do tumor biopsy, and sometimes it is shared in the blood also, so you can check it in the blood. You do biomarker analysis, and accordingly you give personalized therapy. You can do actually screening to check whether it is working. So it is also very simple these days that you take a biopsy and you can grow them, and you can actually check the drug response also out of those things. Okay. So this is the way. I will show you more details about that. So when you identify a drug, so when in our labs, right, most of the academic labs, we do preclinical research. So we test it in the animal model, we do a toxicology in animal model, which do ADME and all these things. Then it goes to phase 1 clinical trial, which have relatively less number of people. Okay. Phase 2 has more, and phase 3 has a lot more number of people. That's the only difference between phase 1, phase 2, phase 3. Okay, and once it crosses all the phases, then there is FDA approval in phase 4, and then it is commercialized. Okay, and then biomarker development also undergoes through the same thing here. So phase 1, screen for potentially prognostic and predictive biomarkers to explore in future phases, consider PGX, and then you just keep going. Okay. All right, so liquid biopsy is also getting very popular now. So it detects circulating tumor DNA in blood. So most of the tumor cells, they shed DNA which is going in the bloodstream, which makes sense because they metastasize, blood gets all the DNA. So this is very non-invasive process. You take it out and you screen for these things there. Like I told you yesterday, sugars are also shed in the bloodstream, and by sugar pattern also one can predict cancer long before it manifests. Okay, so monitoring for emergence of resistance mutations. So tomorrow I will show you that when you give these famous drugs for EGFR receptor thing, they develop resistance. So how do we tackle those resistance? So when you are giving a drug to a cancer patient, you have to closely also monitor how the person is responding and what kind of resistance mutants are emerging. Okay. So, and then AI can always, step in. So the advantage of AI obviously is that humans can see these things at one time. They can look at the entire spectrum at the same time, and they can score it. So if we look at immunohistochemistry images, we see very few things, and they can see every single dot there, right? So they can aid us in real accurate diagnosis. Okay, so this is called polygenic risk scores, or PRS. So AI can aggregate thousands of small genetic effects to predict drug clearance more accurately. Okay, this is becoming quite common now. So key takeaways for PGX: safety first, test for these genes, prevent severe life-threatening toxicity. Somatic testing guides allow us to do target selection, and these are the consortiums. They provide actionable dosing recommendation. If this is absent, this is present, this is effective, this is not effective, they will tell you. And the future is that you do liquid biopsy and use AI to further personalize oncology care. All right, all right. So these two were quick lectures, about 30 slides each. So now let's start the next one. Okay.